Good evening and welcome to Heartbeat. I'm your host, Arlana Shikongo. Suicide is one of the leading causes of death around the world, but it's an aspect of mental health that is not talked about enough. According to police statistics, 565 people in Namibia took their own lives between April 2020 and April 2021. Experts have said that Namibia's suicide rate is amongst the highest on the African continent as well as globally. So, ahead of Suicide Prevention Day, which is observed on 10th September, which is this Friday, Heartbeat and a panel of experts will discuss suicide to get an understanding of what may lead somebody to contemplate taking their own life, as well as the services that are available to somebody suffering from suicidal ideation. Joining us in studio today, we have specialist psychiatrist Dr. Lahija Hamunjela, who will be with us via Zoom, as well as two social workers from the Ministry of Health and Social Services. We have Emilia Newaya and Selma Uugwanga, both of whom are also members of the Comas Suicide Prevention Task Force. Ladies, thank you so much for joining us this evening. I hope that we have a fruitful and productive discussion on suicide. As I said, a much needed discussion to have because the suicide rates, not only around the world, but in Namibia as well, are extremely alarming. So to start us off, I'm going to start with Dr. Hamunjela, just to discuss the mental health aspect of suicide, knowing and having an understanding, at least for us, but maybe not for the general public, that suicide is an outcome of dealing with mental health issues. Just give us an introduction as to what suicidal ideation is and what the signs and causes of contemplating suicide might be.
Okay, thank you for the question, Elian. If we are to start with the definition first before I go to suicide itself, ideation, suicidal ideation simply means that this person is having thoughts of ending their life or they feel they're not worth while living. So they always think about ways, try to find out why. You find them even researching on ways on how to die if they attempt it, whether by jumping, by whatever they can find. But suicide by itself now then means that this person intentionally planned to end their life, and they therefore succeeded in ending their life the way they wanted it to end.
Yeah.
Whereas in ideation, it can just mean the person has the ideas in the mind, it comes here and there based on what they're experiencing around themselves that day, be it environmental or be it just stress at work. And then they feel, okay, what if I die?
Yeah.
Can this not solve my problem?
Yeah.
But we are now also saying suicide plays a part of mental health, mental illnesses. And it doesn't necessarily mean that just because somebody killed himself, they had a mental illness. We're just saying that majority of those who end up committing suicide successfully have a mental illness. These kind of mental illness are now such that especially mood disorders, because most of the time they feel, especially if they're irritable or they are too overly happy or they feel unhappy, then they are most likely to succeed. And secondly, we have what we call when they fall in the psychotic group, which means they are hearing voices. In this instance, it's not the individual himself that want to commit suicide, but rather the voices that are commanding him or her to do that. And therefore they feel that this is a reality they live and they cannot get away or break away from it. So they feel they need to do that.
Absolutely.
The other one is substance use, dependency. Remember somebody who used especially alcohol and those who use intravenous substances are at high risk. We say they are 20 times more likely than the population to complete this, because it depends on what they're using to inject. And secondly, if it is alcohol, it's during the time of alcohol, when they're intoxicated, that they hear the voices and then they follow what the voices is saying, or they lose control of their impulses. They become impulsive, more impulsive, and they dare others and themselves to jump or to end that thought of killing themselves at that particular time.
Thank you, Doctor. That is very, very insightful. Now, you mentioned a number of things that may lead somebody to want to end their own life or take their own life. And research shows that self-harm, one of the things that you mentioned, is one of those elements as well. And a lot of times those elements of self-harm will lead somebody to eventually taking their own life. So I'm going to pass this over to Emilia. If you can just talk us through what self-harm is and how it might lead to somebody committing suicide.
Okay, it's a good question. But I want to highlight a very important aspect before I go into the definition of self-harm and how it leads to suicide. In actual fact, self-harm and suicide is not the beginning of everything. The person is in a certain situation or is faced with a problem. And being in that situation and in the problem, they are thinking, they are planning, they are exploring on what they should do to solve the problem. So during this period of time, the person can come to conclusion that I cannot have a solution anymore. I have been thinking and planning, and probably I have been portraying certain symptoms and signs, warning signs, but nobody notices it. Or at times I have spoken to somebody, because sometimes people make comments, suicidal comments, that I want to die. I just a lot of comments about suicide, and nobody notices, or if they tell somebody, somebody laughs about it. So it's not taken seriously. So the person finds a solution, which is to harm themselves. So self-harm itself, it's an intention to harm oneself as a manifestation of psychological or social disturbance. But the two interlinks, because self-harm, the person does not have an intention to end their lives. We hear in most cases that when people, for instance, they use blade to cut themselves because they had an emotional distress. So they try to ease the pain because, come on, I'm crying for help and nobody hears me out. So let me just ease this pain. But how it interlinks is that in the act of self-harm, a person can end their lives, because if you cut yourself with the blade, maybe you cut your veins. What if you lose more blood and then you die instantly? It means you died by suicide. And as well, suicide itself, it's an intention really to end your life. And as well, this person has been trying to cry for help and could not get help. So they decided that, no, let me end this pain just by ending my life. So they reached a point, they reached a solution to solve this problem. So the two interlinks. Self-harm is done with the intention to ease the pain, while suicide is done with the intention to end one's problem or one's situation or hurtful feelings. I hope this answers your questions.
Absolutely, it does. And you spoke about warning signs that people try to cry out for help. And Selma, I'm going to pose this to you. In terms of warning signs, what are the things that somebody might display that indicates to you that this person might be thinking about suicide?
Okay, some of the signs that a suicidal person might have, it's they might feel helpless. They might feel like, okay, I'm just here, I have nothing to do, nobody cares. And sometimes they might display mood swings. they are not, today they are feeling this type of way, tomorrow they are feeling the type of way, they might withdraw from activities that normally interest them. They would normally love going out with their friends. Out of the blue, they just shut down and they just create that boundary that, no, I don't want to go anymore. Or they can start giving away their belongings. For example, you take my car one day, you take my this. So it's like they're preparing the people, but most of the time we do not take note of this. We might not be able to spot out these signs. They can also be behaving recklessly. They might be driving with the intention of bumping the car into the next car. They might know that, okay, I'm walking and there's a car passing by, and they would just run into the road. It's some of those signs that we do not notice about these people. They might be abusing alcohol. Suddenly someone is drinking every day, drinking out of proportion. It could be a suicidal sign, as well as feeling tired most of the time. Every time you're fatigued, every time you feel like, I'm just unable to, I don't feel like I can continue anymore. That is why they come to make statements such as, I'm not valued, it's better if I die, I think everyone else can move on without me in their life. So those are some of the signs that suicidal people display.
And we're going to talk about that as well closer to the end, just things that people should be cognizant of when they hear statements like this or notice actions like this from the people around them. But before we even get to that, I think it's really important for us to get an understanding of what is happening on the ground. We have, very vague figures that we sometimes get from the police, but we don't necessarily get demographic figures. Are adolescents being affected more? How are the elderly people looking like when it comes to suicide? So just from the data that the Ministry of Health can provide, I just want us to look at, first of all, the overall statistics for suicide in Namibia, and then gender demographic statistics for suicide in Namibia as well. Emily, if you can assist us with that.
Okay. In actual fact, today we would like to make people understand that suicide is very, very serious in Namibia, and it should be taken very seriously as well. So there is a provision of this statistic, which is from the January 2020 to June 2021, which means from there, June 2021 up to date, the statistics are not provided. So in actual fact, in these statistics, it involves adults, males and females, juveniles, females and males. The overall number of cases in Namibia is about 745.
And that is in this period, June 2020 to...
Yeah, in this period of 18 months.
Okay, all right. That's a very high number in comparison to the figures that we got for April around the same period of time. And you can go into the demographics if you have those statistics as well. So for the adolescents, juveniles, and then you said male and female as well.
So as the statistic indicates that the males, within that period, there are 609.
Okay.
While this is now adults. While the females are 101, and the juveniles which are children, they are 22, and the females are 13. When we compare this number of cases, we could see that there is a high number of cases when it comes to males, being children or adults. And this is there's a reason why, because males use a lethal way of ending their lives, while women prefers probably to overdose. And most of the women are rescued as survivors, because when you overdose, at times they have a chance of being rescued, being taken to the hospitals and be treated as such.
Okay. You said with males they use a level way. What do you mean by a level way?
It's a difficult way of ending their lives, which means in most cases you hear that men hanged themselves, or they used guns to kill themselves.
Okay, and those are ways that are almost instance, no?
Prevalent in the men that uses more than the females.
Okay,
Yeah.
all right. And then, Selma, if you can help us with, I think actually, Emily, you went in a little bit into the age demographics as well, but maybe regional statistics, if those are with you at the moment.
Yeah, I'm gonna build on what my colleague said. These statistics are between the time frame of January 2020 to June 2021. So it's a period of 18 months. So we find that in the regional statistics, Omusati has recorded the highest number of cases, which is 111 cases, and then Omaheke being the least with 11 cases.
Okay.
When we move on to the juveniles, because what I gave now is for the adults.
Okay.
When we move on to the juveniles, we have Oshikoto topping up with 8, and Kavango West that had none.
Okay.
So there is those of the ones that I spoke right now obtained from Nampo.
Okay.
So the one for the suicide attempt and ideation are collected from the Ministry of Health and Social Services, which brings us to Komas having 330 and Kunene having 36. So those are the regional statistics that we have so far for the period of 18 months.
Okay. Is there a reason why for the ideation, the ministry collects that information rather than the police?
Let me chew a little bit on that.
Okay, sure, no problem.
Yeah,
because
It's because the Ministry of Health, we receive the cases on suicide attempts and ideation.
okay.
The police is always the one that is
At the
available
scene,
to
yeah.
collect the corpse
Of
whenever
course,
somebody
okay.
completed the suicide.
Okay, absolutely.
So adding on to that is that when we get these cases, when the clients come, we refer, because suicide is not a one man's job. It's a multidisciplinary team. We have different stakeholders that deal with the suicide related cases.
Now, what that indicates, just looking at those figures, if we have to put them in terms of the suicide rate, the World Health Organization provides figures that indicate that Namibia's suicide rate, which is now looking at how many suicides happen by population, our suicide rate is one of the highest in Africa. And Africa as a continent has the highest suicide rate in the world, which is a very alarming figure and statistic to try to navigate through. So what I'm curious about is, Dr. Lahija, if you maybe have more specific data sets as to how our figures compare to the rest of the continent.
Have more data, but I just wanted to put things in categories, the way we look at it.
Okay.
Applying evidence-based practice. My colleague said lethal ways or lethal weapons that are used by men, therefore giving us a high number as compared to women. That is because we look at, they use guns, and a man, when he's determined to kill himself, he is not joking like female would be like joking to see how many people would then come to their side to give them attention. So therefore they go for things that they know that, one, the weapon that they use will actually lead to death. Secondly, they will choose a time where they know that nobody will be around to see them. If ever somebody is to come, they will find them already dead. Number three, they make sure that they never actually hardly really share with other people as it is with women. We share what the plan is. Fourthly, also is to know if there is a genetic predisposition or family history of suicide in that, then it is very high already in that person. As opposed to women, we are saying we use minor methods to actually just see if we can get that attention or get what we really wanted from that person. For example, we use pills, as we say, overdose, tablets overdose, because that is what is more common. And the type of pills that female use is not the type of tablets that a male will use. The male will know exactly which tablets to use that will caused him to end his life. Whereas for female, you find when you ask them, they tell you they have taken 8 tablets of Panadol. So Panadol is not as lethal as compared to some other medication. It's also the way we do. Or some try hanging by what? By toilet papers. Toilet paper will not kill you. And another thing is also because of the stigma that is associated with suicide. That is why a lot of our statistics are not reported where it's supposed to be. So for now, we are saying anybody who overdosed at home or attempted to kill themselves will come through casualty, be it Katutura casualty or be it the private casualty. Then from there, they are referred normally to a social worker if they have excluded every other damages or any other complications. Then they will then discharge them through a social worker who talks to them while they're in the hospital. Okay. So when they are discharged from the hospital, at that moment, you cannot say it's suicide because the person is still alive. Yeah. It's not suicide. So then after that, you discharge. Everybody is discharged through mental health. So the mental health will then have both the statistics of the ones that went via the hospitals and the ones that just came straight from wherever they came from. Because mental health hospital is the only one that deals with that. And also take into cognizance that if it's a private institution that admits our people, para-suicide, a lot of hospitals nowadays refuse to admit somebody who attempted suicide. So there's only Bell Esprit, which is the private one in Olympia, which can then admit, but is also given a limited number of days to admit that person. So which can at least go to 2 weeks, but in other hospitals they refuse, or if they admit, it's 2 days. And 2 days we're saying that you cannot treat a person and resolve the underlying cause of him having attempted suicide. So you need to look at all the other things.
Absolutely. Yes. And doctor, I just want to get an understanding of why a hospital might refuse to admit somebody who has attempted suicide. Why would a hospital refuse somebody? Because does that not indicate that psychologically or emotionally that person is experiencing some sort of turmoil?
Yes, that definitely indicates that, but every house has its rule. And unfortunately, mental health in this country receives less attention than it's supposed to. So the stigma does not only come from society, it comes also from within the medical fraternity and within the people who are working in the hospital. You are finding somebody who attempted suicide, you don't even start to question the person to say what was the cause of this? Is there something immediately we can do? Build a rapport before you can even say, this is Dr. Lahija's patient. Do you know we are the only one who has patients by name? A psychiatrist, you will be told this is Dr. Lahija's patient, or this is Dr. Njaba's patient, or this is Dr. whose patient, because we are the psychiatrist. But that suicide is not the main problem in that particular patient. So like my colleague was listing there some of the symptoms the person are having, why they would feel worthless, low, feeling loss of appetite and whatever. Those are symptoms of depression. And we are saying any mood disorder puts you at a high risk of committing suicide because you are already in that dark spot, and all you need is somebody to listen to you, somebody to bring you out of that dark spot into a light. So sometimes you yourself, you don't know. You can go 2 years being depressed, and they will call it persistent depressive disorder. But you don't know. It could be a trauma that a person had gone through, but the body decided to shut off until something happens that will trigger a bit, until some of the memories come, or you just feel like you end your life not even knowing that what was the trauma that actually led you to be feeling so depressed for no reason for 2 years. There is always something underlying.
Absolutely. And what that speaks to, Doctor, is that there needs to be a culture shift, because even if the mindset and the culture on an institutional level is so oblivious to the impact of having a mental health problem or a mental health illness, or even just dealing on a temporary basis with some sort of mental health incapacity, does not recognize the seriousness of that, how exactly is the person on the street supposed to take their sister or brother or cousin seriously when they say, I don't feel good today, I need help? So there definitely needs to be a culture shift. And just based on your experiences on the ground, what kinds of things do we as a people need to change in our perspective when it comes to not only suicide, but also how we think about mental health? Emily, let's start off with you.
Okay, when it comes to suicide and all other social problems...
And she's hiding.
Doctor?
No, she was just saying you're hiding, but I think it's just how the screen is positioned.
Okay, but anyway, paradigm shift is needed. As time changes, everything changes. We have a lot of myths when it comes to suicide and other issues. Because in the past, suicide is seen as the person is being coward, not to be able to face a certain problem, or not to be able to deal with their own emotions or feelings. And they are viewed as being troublesome, or they are viewed as being not able to help themselves. However, for the myths to change, hard work is needed as well, from all aspects, from people themselves and from professionals. And it's really at the right time that we introduced the case SPT, the task force, for us to address things pertaining to suicide, to address the myths as well, to make people understand that suicide is an issue, it's a social problem, just like as any other problems in life. And people have different personalities, and the way I take certain problems, or the way I deal with problems, it could be different from you or from Selma. Everybody takes problems the way they are. I could be strong in a certain situation, the next person could struggle with that situation, or some people are not openly speaking about issues as well. So it doesn't mean that person, I'm being good and the other person is being bad or coward. It just means people have different personalities and have different ways of dealing with problems and issues.
Absolutely. And that actually makes me think about, as we're focusing on mental health and suicide in a grander scheme, COVID, for example, has exacerbated a lot of people's problems with unemployment. People are finding themselves in situations of poverty. They have to deal with the difficulties of not being able to afford rent or food. And a struggle like that, or even experiencing COVID, having COVID, or losing someone to COVID, is a traumatic experience that can very quickly send someone into a very difficult place. So do we have any understanding or any statistics or any insight as to how COVID has changed the landscape of mental health and suicide in Namibia?
I completely understand your point, and I do get you very well. However, we are working with evidence-based, and until this point, we do not have a study to prove to us the effect of COVID-19 or in regards or the relationship between COVID and suicide. So if there's any researcher, they can come on board, because we really want to assist, and we are welcoming any.
Of course, I mean, COVID is a new landscape for all of us, so everything is still being collated at the moment. But Dr. Hamunjela, perhaps you can speak to your experience or the patients that you've seen in the last, how long have we been dealing with this pandemic? 2 years? Almost 2 years, something like that?
Almost 2 years, 1 year and 6 months.
1 year and 6 months.
Almost 3 years now.
Yeah. Has the influx of patients that you've worked with, at least, has there been a higher influx of patients that are dealing with a mental health problem, or a higher influx of patients that are potentially suicidal?
We're talking about quite a change in the way people now approach mental health or look at mental health per se. Initially, if you wanted to visit a psychiatrist, the best thing from my tribe, I'm talking from my tribe, from my people, would be you crazy, you crazy. And we are saying we don't use words like that because you're actually already preventing the person to go look for assistance. We find that we're sitting with families and they're still really isolating the person who needs the help by saying, I don't understand why she just can't get out of that mind setting of hers. You as a family, you are failing the person because it's not the mind setting, it's not a choice, it's an illness. Unfortunately, she doesn't have a scar, or she doesn't have high blood that you can measure, or sugar that you can measure. But this person, just the way she thinks, the way she talks, the way she even pay attention, even the walk, in the way she feels about the life, per se, has changed. It has not changed over a day. It has changed over certain days. So therefore, it has developed into a disorder. So for it to be a disorder, you need a doctor. The only doctor who deals with the brain, emotions, behavior is a psychiatrist and the psychologist. It would have been lovely for a psychologist to be part of this panel to tell us that okay, Dr. Mila, you have dealt with the chemical imbalance that was with the person. But majority of the things are dealt with by psychologists. If it is minor depression, for example, I will just prescribe something light for a shorter period. But the rest of the things, it's a psychologist who need to deal with it and the occupational therapist. A person who comes to your office forever cutting their wrist, what medication will make that person stop? That means there's something else on the way the person thinks and react, the way they react towards something. So they need to be taught on how to deal with that. And for some of us, we don't have time to look. The person will come with long sleeve things during summertime. Why would you want to wear a long sleeved jacket or something summertime? So you need to be comfortable to ask, what is that? Me, would you mind if you take it off and we proceed with our assessment? While you're doing the assessment, you go down looking, because sometimes they want to put themselves in places where nobody else would be able to look into. And a person who cuts himself most likely has a personality disorder, an underlying personality disorder that is going on with that. And a psychiatrist will not solve a personality disorder. It's a psychologist who will deal with that. Okay. So now as we're speaking, is that we are encountering more of increase of the substance use because people are spending more time at home. They have no other places to go and entertain themselves. They have not learned new mechanisms on how to entertain themselves. Secondly, obviously, we find them, a lot of people have depression. A lot of people have anxiety. People who already had phobias, their phobias have become more and more. And those that were already having mental illnesses, either the mental illness has become worse or they were in remission, but now has restarted because of the environment in which they find themselves. So there's a lot of things that we're dealing with. Some of the people have lost their loved ones to COVID, so therefore they cannot handle that death because it's not a natural death. In that they don't have, or they did not have a proper closure to death, as opposed to the normal way we used to put our loved ones to rest. So therefore, you did not go through this. So this person end up either with depression or with PTSD or with anxiety. So we need to be looking after those people who have lost people during this time period of COVID, because it will come out as one or another mental disorder.
So then, just to be clear, doctor, is that to say that you have indeed seen more patients come in during this COVID period?
Yes.
Yeah, okay.
And as a matter of fact, our unit, it was the only unit that did not even close during COVID shutdown period. The outpatient, everybody was coming at whatever time they were coming. We didn't have to say, we're not seeing any patients that are coming there. So you can't let a person go who's telling you I'm suicidal or I'm homicidal. So the fact that they told you I'm going to kill Martha, I need to find out Martha who, the surname, where does Martha stay? Because I have an obligation to warn the next person if this next person is identifiable and the possibility of him being hurt is there.
Okay.
So right now, psychiatry is honestly busy.
Yeah, I can imagine. And that makes me curious then, in terms of what services are available. First of all, are there any figures on how many psychologists and psychiatrists are in Namibia that are able to counsel specifically for suicide? Selma, if you can help us with that.
Yeah, there's no specific number. However, every trained and registered social worker, psychologist, psychiatric do have a role to play when it comes to suicide. It depends on the gravity of the case. Like we do have a referral system. Social worker can refer, as doctor said, refers through Katutura Casualty, then it goes through to the mental health.
Okay.
Yes.
So someone can come to the ministry and say, I need to talk to a social worker.
Yes.
And then there will be a reference process to get that person the counseling that they need.
Yes.
Yeah, okay.
It happens like that.
All right.
And we need, sorry, on that part, having said that part, is the fact that you as a referring doctor or social worker has to be aware, consciously aware of what are my limitations, because that will also put you as the one who's offering the first consultation to a traumatized person, will cause problem to a patient as well as to yourself. We have to be aware to say this much I can go, because we all took it. That much I can't do. In as much as I feel sorry for that patient, but that is beyond us.
I also agree with my colleagues.
Yes.
As Selma already mentioned, also, and doctor is mentioning that we have to be conscious. That's why with suicide, you can't really work in isolation, because the causes of suicide, it could be psychological or social. And as a social worker receiving a suicidal person, I have to do an assessment, proper assessment, to see what problem is this person facing. Let me identify the social issues. Maybe the person there are those people that are suicidal because they have a certain disorder or because of a psychological issue. But there are those ones that are having suicidal thoughts because of a failure in relationship. So that is now how a social worker chip in. You assess and you deal with your part. From there, you refer to the multidisciplinary team, because all of you have to deal with this one person and do your role at your capacity. So that's what I wanted to add.
Absolutely.
And there should be feedback so that we know that we are winning or we are losing.
Yeah, definitely.
Because if we are not giving feedback to one another, these people get lost to follow us.
That's it.
Ideally, we would say we would love to have a case manager for everyone who comes in, but unfortunately not. Our numbers are not allowing us to have a case manager for every case that is coming in.
True.
Okay. And then with the Komas Suicide Prevention Task Force, does the task force do case management, or what exactly does the task force do?
The task force, our first this task force came into existence last year.
Yes.
And we network and collaborate with lining ministries, NGOs, faith-based organizations. The KSPT is just a task force that goes out to create awareness and to promote preventative measures.
Okay.
And to do presentations to people to explain the risk of suicide and to teach them about warning signs, how to identify a suicidal person, and which we have the launch right now on Friday, on the 10th of this month, on Friday right away, so that we can give hope to these people, because we are doing this in the World Suicide Prevention Day, because this is a day that is commemorated globally, not only in Namibia.
Yeah.
To say that there is hope. Like the theme of this year is like taking action.
It's creating
hope through taking action.
Okay.
Which makes us to indicate to people that there is hope. People can be supported and we care for them. This also gives an indication that even every little or big action you take towards the person that's suffering matters. And as well, this will help us also to instill confidence within people out there.
Yeah.
So the Commerce Task Force is just that group of stakeholders that comes together to promote preventative measures. And to address the problem of suicide as such, but not necessarily counseling one-on-one or doing what. It's just to say there is help. You could go here or there. You could do this if you are finding yourself in this situation. These are warning signs. Please watch out for your loved ones or friends and refer.
Okay.
Yeah.
No, and that's very necessary, very much needed.
Yeah, just to add on to my Emily, we do outreaches, okay? And we do this in different constituencies and through the Commerce Regional Council. Just that the COVID pandemic is within us, but we have managed to visit constituencies such as Groothoop and Mixed Settlement. We do this to go and engage with the community. And when you go there, you find out that they want to talk. They want to come out. They have things to say. They have additions. Do this, do that, because this is a community. It's everyone's responsibility, because we are saying that suicide is preventative. So if we all join forces, we are able to yield results.
Absolutely. And before we close off the show, we just have a few comments here that we're going to take really, really quickly. We have R. Jerome Jao says, the state of mental health in Namibia is very poor. There are no reach out outlets for those seeking help or assistance, and most of our health practitioners are not fully equipped to handle or treat mentally unstable individuals. Awareness in mental health in Namibia is basically non-existent. It's more in urban areas than rural areas. We need to do more in terms of mental health in the country. And I think that speaks to, as you said, the work that the task force is doing now with the launch coming up on Friday and already the community outreach that has been done through the task force. And then we have another comment.
I think.
Go ahead, Doctor.
I think, that's a valid because I also have it here because all these years, the celebration of Mental Health Day, which is next month also, the 10/10, it's Mental Health Day, but we have always celebrated it at mental health or at Central Hospital.
Okay.
So we are saying, if we really targeting the rest of the community, why can't we get out of our own comfort zone and do this outside?
Absolutely.
But they are not aware that they are suffering, yet they are having a problem of coming to the hospital itself. And I also agree with the person that mental health is not where it is supposed to be for our population. And I'm speaking for the person who works for the state. For the state, and I keep repeating that, the I say we only have 3 psychiatrists in Windhoek alone. So you take the population of Windhoek alone, divide specialists you have. And amongst that weight, you tell us that we are responsible for prisoners, people who committed an act but were mentally ill, so therefore they were declared as the state president's patient. So this person belongs to the state. Then we are same 3 people you subpoena to any court if you are not happy with the observation we did. And the same specialist also you expect to be on call for the rest of the country, for the rest of the doctors, call if they have a case in front of them with a mental illness. So at the moment, we are saying in the state we are 3 in Windhoek and we have 2 other colleagues in Oshakati. But in Oshakati, we are saying we do not have a hospital as we have in Windhoek, but a wing in the hospital. We just give them a wing. So they have to work within that wing. So I think for the people who are attending for people with mental health, with as much challenges we are getting, we are really also trying.
Absolutely.
So they should invest more. As a thing, the government itself should invest more in mental health. Sending more people to go study. Give the person the first option they put. Don't give the person the third option they put. We put the third option because we always want option 1. So give people for in future, just in the next 5 years, I do not see us having Namibian psychiatrists itself unless the plan is to export.
No, and I think there definitely needs to be a broader discussion on the shortfalls of the system, especially now that we have a clear understanding of what is happening on the ground, not just talking in an ethereal manner about the severity of mental health illnesses on the ground or suicide on the ground, but we have tangible numbers that we can look to be able to say, we don't have enough capacity to deal with a problem this big. And that is definitely a conversation we need to have in the future. But for tonight, ladies, doctor, I am so thankful for you to come into studio and indulge us in this conversation and for providing information that is really needed by the public. I did not get to all the questions that we had. However, I do encourage the audience, as always, please leave your comments, leave your questions, as we do like to pass these on to the experts so that we can get answers and also address any problems that are of pertinence to the nation. However, that is the end of our show. We are going to have to say goodnight. So, Selma, Emilia.
Seriously, I can't let you say good night unless my 2 colleagues were going to say what I'm about to say.
Okay,
that we are actually pleading that on Friday as they are launching, because it's our commemoration or celebration day for suicide awareness. Please wear yellow.
Please wear yellow. Okay. Duly noted. I hope the audience heard that. Please wear yellow on Friday, as that will be the color for the commemoration of World Suicide Prevention Day this Friday, 10th September. And thank you to my guests. Thank you to the audience for tuning in. As always, I'm your host, Arlana Shikongo. Good night.
Good night.
Oh, thank you so much. This information